I'm the FY1 handing over for 504 and 506.
Well, any transition from one system of care to the other is an opportunity, to put it bluntly, for things to go wrong. As hard as we try and make the night as active and similar to daytime, there clearly are differences. Staffing levels are lower, people want to sleep, they're not able to tell you when things are going wrong in the same way.
The process of handing over for doctors, no matter what level, can be really quite stressful. They're at the end of their shift, they've got a lot of information on board, and they're having to hand over in a concise way.
You can have a bad handover whereby you're given the wrong information about a patient, so if you're told something about a patient's condition or their management plan that isn't correct, again that's putting the patient at risk.
She wasn't tachycardic, heart rate was 70, and all her other obs were normal.
So we have 2 large teaching hospitals and 1 fairly large district general size hospital. When we looked at instances where things had gone wrong, often part of the problem was that the hospital at night team weren't aware of patients who were sick and getting sicker, or perhaps weren't aware of every important aspect of those patients. When we unpacked them, did root cause analyses, we found that communication failure was part of it, so we had those examples.
65. So he hasn't actually informed the surgeon.
There was more that was the same that was different. Some of the differences, however, related to geography. So on one site, for example, the nurses were for a substantial amount of the handover in one room and the doctors were in another.
At the Royal, certainly, we shared an office with another group of people that weren't on hospital at night, and so it would get very noisy.
As registrars, we can be sent to any of the 3 sites to work overnight. The junior doctors themselves, they rotate through all 3 hospitals generally as part of their training. So it's very important that no matter where you work, day or night, that you understand that there is a way to do things.
I think the handovers had got a bit of a bad name for taking rather a long time. And this was something we noticed. There seemed to be an awful lot of conversation with people seeking out the right bit of information to give. Information was recorded in different ways, but perhaps more importantly, the people going to the meetings didn't really have a feel for what exactly it was they were supposed to hand over, what the priorities were.
I think sometimes people take it for granted that those skills are there. I think we're finding we've got to be much more explicit about the content, about the way it's delivered, what kind of atmosphere it's delivered in.
She has had a chest drain removed. It was in for a pleural effusion, taken out this afternoon.
We literally mapped out in some detail what an ideal handover would include within it, with some very basic things like who the patients were, who was in the room. We used the same approach, hierarchical task analysis, combined with an understanding of human factors, to look at what made people perform at their best, what made them most relaxed, how to almost coach them through the handover.
We've used SBAR, which is Situation, Background, Assessment and Recommendation. It's a well-known kind of method of communication, as a way to encourage them to hand over.
Since handover's been changed and the SBAR form has been introduced, we have a much more structured way of handing over, telling us exactly what they want us to do and why they're wanting us to do it. Also, we've made sure that on each site we have our own dedicated room, so that we're not interrupting anyone else's work and they're not interrupting us, and that's worked much, much better.
Once they were able to fill in the form, it was then about developing a structure and trying to improve the process of handover. And so the teaching module that's been developed is very much about giving them a process to go through, so they know that it's important to hand the sickest patients over first. They get 2 sessions. They get a session in their first ever week working, the foundation doctors, and basically that's very much about just telling the basis of handover. Why is it important? It's about patient safety. It's about giving them the best care that we can. The second training session is about 3 months in. They get given an SBAR form, they get given a scenario, and then they hand over to me.
One of the challenges we had was figuring out how to measure quality improvement. And something that we learned through literature reviews and talking with the Health Foundation and so on was this concept of the surprise. If I was the registrar and I went to a ward expecting to see one patient who was having chest pain and I turned up and the nurses said, "Thank goodness you've arrived to see the man who's bleeding," that's not what you expect, and it does immediately imply that there was something you should have known but didn't.
If we have less surprises, then our care of patients is better. So looking at, say, over the last 6 months, from kind of August of last year to February of this year, the average number of surprises per month in the Royal Infirmary was about 70. We're now down at around about 30 per month.
The hierarchical task analysis was useful as well because it didn't just give us a map of where all the risks, the tasks were and the inherent risks. It allowed us to put some measurement behind them. So we could produce a number to say, this is the sum total of the inherent risk in the system. And by doing the improvements and repeating the exercise, we could see the number go down. The most immediate, if you like, value for money impact was that whereas before, on average, the handovers were taking an hour at least, when they're working well now, they're taking sort of 20 to 30 minutes.
Thanks very much. I've definitely noticed an improvement in the handover of some of my less experienced colleagues now. I've noticed that they tend to be more concise if they're using the SBAR format and the SBAR form in particular. And I think they tend to be more confident that what they are giving us at night is the right information.
I think it's been really important to show benefits to patient care, and the trainees in their annual feedback report have been really complimentary about the training that they've undergone.
I don't think anybody really disputed that handover was something we could improve. I think we had to make the case with a hospital at night team who had lots on their plate at the minute that this was an important thing to do. But actually it wasn't that hard.